In rheumatoid arthritis, the immune system is not simply overactive. It is specifically imbalanced. Too much inflammation being driven by one type of immune cell and not enough regulation from another. In this video, we explain how vitamin D, not as a supplement but as a master regulator of over 1,000 immune genes, corrects that imbalance at the genomic level, and why standard supplementation almost never gets the job done. Let's return to the fundamental immunological problem in RA, TH17/Treg imbalance. Too much inflammation, not enough regulation. Conventional therapy suppresses inflammation, but it doesn't restore regulation. Here's where vitamin D enters as the master immune regulator. The vitamin D receptor, or VDR, when activated by 1,25-dihydroxyvitamin D, the active form of vitamin D, regulates transcription of over 1,000 genes. In T cells specifically, VDR activation does four critical things. First, it promotes regulatory T cell development. VDR directly upregulates FOXP3, the master transcription factor for Tregs. It enhances Treg suppressive function through IL-10 production. Second, it suppresses TH17 differentiation. VDR activation blocks ROR gamma T, the transcription factor that drives TH17 development. It reduces IL-17 production. Third, it reduces B cell antibody production. VDR activation in B cells inhibits plasma cell differentiation and antibody secretion. Fourth, it modulates macrophage function. Shifts macrophages from M1 pro-inflammatory to M2 anti-inflammatory phenotype. This is not theoretical. This is genomic regulation of immune function at the cellular level. And this is why vitamin D status is critical in RA. Multiple studies show RA patients have dramatically lower vitamin D levels than healthy controls. One meta-analysis found mean vitamin D levels in RA patients were 24.5 nanograms per milliliter versus 31.5 nanograms per milliliter in controls. Prevalence of vitamin D deficiency below 20 nanograms per milliliter in RA patients ranges from 60% to 90% depending on geography and study population. Lower vitamin D levels correlate with higher disease activity scores, worse pain, more tender joints, and greater disability. This is not coincidental. This is mechanistic. But here's the paradox we discussed earlier. Clinical trials giving RA patients standard vitamin D supplementation, 1,000 to 4,000 IUs daily, show minimal benefit. They successfully raise vitamin D blood levels, but disease activity doesn't improve significantly. Why? Because in RA, vitamin D metabolism is broken at three levels. Level 1 is impaired conversion. The enzyme 1-alpha hydroxylase, which converts 25-OH vitamin D to active 1,25-dihydroxyvitamin D, has reduced activity in RA patients. You can have plenty of storage vitamin D in your bloodstream, but if conversion to active form is impaired, cellular VDR activation is inadequate. Level 2 is reduced VDR expression. RA patients have fewer vitamin D receptors in synovial tissue and immune cells. Studies show significantly reduced VDR messenger RNA and protein in RA synovium compared to osteoarthritis controls. Fewer receptors means less capacity to respond to vitamin D. Level 3 is VDR polymorphisms. Genetic variants in the VDR gene, FOC1, BSM1, TAC1 polymorphisms, alter receptor function, reducing transcriptional activity and cellular response to vitamin D. These variants are more common in RA patients and correlate with disease severity. This triple dysfunction is why standard supplementation fails. You need much higher levels of substrate to overcome impaired conversion, saturate reduced receptor pools, and compensate for genetic resistance. Standard medicine targets 25-OH vitamin D levels of 30 to 50 nanograms per milliliter. They call this normal or sufficient. Our clinical data shows this is completely inadequate. For active rheumatoid arthritis with established disease, remission is achieved and sustained only at 120 to 180 nanograms per milliliter. Not 60, not 80, not 100. 120 to 180 nanograms per milliliter. Anything short of this doesn't work. This is what we observe clinically with over 7,000 patients. Below these levels, patients plateau. They improve somewhat, but they don't achieve sustained remission. At these levels, with proper cofactor support and monitoring, we see complete immune remodeling. TH17 cells normalize. Treg populations restore. Inflammatory markers drop to normal, CRP below 1, ESR below 20. Disease activity scores reach remission criteria. DAS28 below 2.6. Joint erosions halt on imaging. Antibody titers decrease. And this is why standard supplementation fails. You cannot reach 120 to 180 nanograms per milliliter with 2000 IU daily. You cannot even reach it with 10,000 IU daily in most RA patients with severe vitamin D resistance. You need therapeutic loading protocols, individualized dosing based on body weight and severity, and continuous monitoring and adjustment. This requires medical supervision by physicians trained in high-dose vitamin D therapy protocols. In the next part, we lay out the complete protocol. All 7 pillars, from the comprehensive metabolic assessment to vitamin D and cofactor optimization, gut restoration, infection clearance, thyroid correction, metabolic intervention, and the lifestyle pillar that most people get completely wrong. We also cover the month-by-month clinical timeline, exactly what to expect and when. And if you want the complete picture, the full 2-hour RA Masterclass is linked in the description below and pinned in the comments.